Algorithms are just visual summaries of best practice guidelines for specific obstetric problem. They are for the big picture purpose. They turn the long textbook and protocols into clear sequences of decisions and actions, so that in the crisis, we don't miss the critical steps and everyone on the team is working for the same plan. This standardization is known to reduce errors and improve the maternal and fetal outcome. In the high-risk obstetric algorithm, today's topic is placenta previa. If there is a high index of suspicion for placenta previa, that can be with a history of antepartum hemorrhage. Perform the physical examination, presence of risk factor, confirm the gestational age, exclude other causes of APH, and confirm the vertebral bleeding. Perform an ultrasound to confirm the diagnosis. Is there active bleeding? If it's no, then continuous outpatient management, regular prenatal visits, serial ultrasound examination. If there is an active bleeding, yes, then is the bleeding excessive or the woman in a hemodynamically unstable? If the patient is bleeding excessive or the woman is hemodynamically unstable, then if it is yes, then initiate the treatment without delay, admit to hospital, place 2 large bore IV lines, CBC, TND, coagulation screening, urgent MFM, anesthesia consultation, fluid and blood product resuscitation, and consider immediate delivery regardless of the gestational age. But if the bleeding is not that excessive and the patient is not hemodynamically unstable, then initial management, admit the hospital, do the routine test, CBC, TND, coagulation screening, IV access, active TNS, consider MFF, anesthesia consultation, fluid and blood product resuscitation, and further management depends on the gestational age. But further management, which is dependent upon the gestational age, is previable. That's less than 24 weeks. Consider outpatient management. Consider bed rest, pelvic rest, regular prenatal visits, serial ultrasound examination. And at 24 weeks, consider admission to the hospital and antenatal steroids. And further management depends on the gestational age. If the patient is between 24 to 36 weeks, continued expected management. Consider bed rest, pelvic rest, initial care if bleeding. Consider outpatient care if minimal and infrequent bleeding. IV access, active all the times in inpatient. Anesthesia, NICU, MFF consultation. Administer antenatal corticosteroids, serial ultrasound examination, and consent for cesarean and a possible need for further surgery, sometimes cystectomy and blood transfusion. Again, if the pregnancy is or the gestational age is more than 36 weeks, elective C-section recommended at 36 to 37 weeks. After confirmation of the lung maturity, consent for cesarean delivery and possible need for the further surgery and blood transfusion. Vaginal delivery may be option in very, very selective circumstances. And this is the algorithm chart for having the high index suspicion of placenta previa. And by ultrasound, bleeding depends. And if the bleeding is excessive and patient is hemodynamically unstable, then the treatment is different. But if the patient is not hemodynamically unstable, then the initial treatment depends. And all the treatment depends upon the gestational weeks also. If it is less than 20 weeks, 24 to 36 weeks, and if it's more than 36 weeks, all the treatment pattern goes on. Thank you so much.